Good evening, everyone. I'm Majid Ashur. I'm a interventional radiologist from Jeddah, Saudi Arabia. So it's an evening in Jeddah here. It could be afternoon in Europe or morning somewhere in the world. We are happy to host today the Saudi Society with Angiodroid this webinar. And it's our pleasure to welcome you all for this webinar, as well as we welcome our eminent speakers. First, I'm going to introduce Dr. Manzi. Is known to most of the people in the world. He's a vascular interventional radiologist. He's the director of the VIR unit in Abano, Terni, Italy. And our second speaker is also Dr. BinKhamis. He's a consultant interventional radiologist working in King Faisal Specialist Hospital in Riyadh in Saudi Arabia. He also do a lot of work, and they have also automated CO2 injector. We've been using it for some time now. As we know, the topic CO2 right technique. CO2 nowadays utilization is not only restricted for patients who have impaired renal functions. However, it's becoming like a more routine use in some of the centers, and especially now with the inventions of automated CO2 injectors. Our speakers today will give us a broad coverage of CO2 use in vascular interventional radiology practice. So I would like to welcome both of you, Dr. Shagran, Dr. Manzi. And the first talk will be with Dr. Shagran. He's going to talk about the role of CO2 in interventional radiology. Dr. Shagran.
Good evening, everybody. Today, I'm going to be talking about the use of CO2, mainly in peripheral vascular disease. So this is what we're talking about tonight. We know CO2 from a long time ago. It has a lot of indications, a lot of different uses, not just for patients that have impaired renal function, but can be used in so many different things. So I'm going to be discussing a bit of the basics, a bit of intermediate stuff, and maybe a little bit of more advanced stuff as we go. My topic will be about 20 to 25 minutes, and depending on the time. And then after that, of course, Dr. Manzi is going to be following with his lecture. So here are my disclosures. So this is the outline of the talk. So in general, it's very hard now just to know what the audience is in terms of the level of their use of CO2. So as I said, we're going to be having a mix of everything, some of basics, some very specific things to PAD, some things that might seem basic, but some people might not know. We always can learn as we go. So let's start off with a poll question. How do you prevent contrast-induced nephropathy at your institution? So is it mainly by using the pre and post-procedure hydration, N-acetylcysteine or sodium bicarb? Are you using mainly dilute or very low dose of contrast, or are you almost always using CO2? So I think we have very good live answers so far. So it's leaning more towards the use of CO2, approximately 60%, and 35% towards hydration, and then maybe 10 to 15% toward low dose contrast. So this is very promising, and I really enjoyed this answer, since most people are switching to more use of CO2 rather than giving contrast, although most of the time we'll be using a mixture of all these together. We're going to talk about CO2 as contrast just for people that are not familiar, that are not using CO2 still. So it is basically a gas. It has no smell, it has no color, and does not combust with time. Always the question a lot we get is there any limited, or what is the maximum volume you can give? In theory, you want to limit it as much as you can, because it is still something that needs to be expelled by the body, and usually expelled by the lungs. But if you want to just you can give pretty much no specific maximum dose. Most patients, you'll not be able to give that much of a high dose, because with time and with more injections, they're going to have, if they have any lung problems, they're going to have pulmonary hypertension, for example. If they have CLI, which is what we're talking about today, they're going to have more pain the more you give CO2. So you're going to not be able to give a huge number. And our practice, our experience is usually for working for peripheral vascular disease, we almost never give more than 150 to 200 cc's of CO2. When you work in the aorta for aneurysms, that's a pretty different story. There's no allergic reaction, does not affect the kidneys or the liver, okay? It's very compressible, and of course it's cheap, which hospitals are going to love. I know Dr. Manzi is going to be talking about this and how the cost saving of using CO2 as a contrast agent helps out in the long run. And again, it is extremely excellent for limiting contrast agent. So notice I used the word limiting. I didn't use as alternative. Okay, so it's a very important to understand that CO2 is not only something that you can use instead of contrast, but you can use something as a complementary agent. So these are the four main features about CO2. It displaces the blood. It does not mix with the blood. So that is what we have problems with CLI patients, because sometimes they get a degree of ischemia. So if they're already in advanced stages of gangrene or rest pain and this kind of stuff, they have more pain if you're injecting below the knee, and makes it a bit more difficult. We'll talk about that in the next few slides. It has very low viscosity. It can go into very tiny spaces, very tiny vessels. It finds a lot of things that you might not see with contrast. For example, small AV fistulas, small shunts. It makes sometimes the dissections look a little bit worse. It can find endo leaks very well, but sometimes it can overcall it. So it comes with time and experience of what to call and what not to call. But it just tells you it's very versatile. It is very soluble, so it dissolves in blood very fast and expelled by the lungs, just like we said. So there's no kidney stress at all. The picture on the top is just showing how it mixes or pushes the blood away. So if it doesn't push the blood away enough, you'll basically have different layers of contrast, of CO2 versus blood. You can use that to your advantage. This is called buoyancy. So let's say you're imaging the aorta, which we're not talking about today, and you miss the renal artery. If you just tilt the patient to one side, you'll let the gas go to one other direction, instead of just increasing the volume or the pressure of the CO2, which might cause more pain. This will give you images and of better areas just by elevating the area of interest. So what are the indications? Everybody knows the top two are renal insufficiency or contrast allergies. However, patients that have diabetes, hypertension, or high volume procedures are at risk of developing contrast-induced nephropathy to a certain degree. In our population, we have probably the highest per capita incidence of diabetes in the world. So we try as much as we can to limit our contrast as we go. Even if we're not using CO2, our contrast is extremely, extremely diluted. It's not just 50%. Sometimes our contrast is 80% dilution in a lot of our patients, and we get very good images with that. There are other patients that have CIN risk, which we all know this from basic teaching of radiology or of contrast agents in CT. So the older the patient are, they have multiple myelomas, all these kind of things also have risk. So if you think of all these patients, you'll be doing a large number of CO2 angiograms or CO2 images rather than using contrast. So we talked about this as a contrast. Now the more focus of our talk is the setup. So let's go to poll question number 2. So if you in the audience do not use CO2 that much, or you don't use it a lot, or you don't use it at all, can you give us what is the main reason that you don't use CO2 in your practice? Is it because you're not comfortable using this agent? You never used it before, you're not happy using it, or you don't have the appropriate connections to do the CO2, or you don't have an automated injector? Okay, so I guess we have probably a good idea now, but so it's a bit of a split between people not being comfortable using it versus not having an automated injector. And very minimal people say they don't have the appropriate connection. So it's about 10%. So the reason I put this question up is because a lot of times I ask people, how come we don't do CO2? Or they refer patients to us and they say, oh, we don't have an injector, which to be honest is not really a good answer in my opinion, or probably even the company's opinion, because the injector is a facilitator to making you use CO2 easier, but it doesn't mean that if you don't have an injector that you cannot use CO2. I think the most appropriate answer for this should be that you're not comfortable using it. So if you're not comfortable using a product or an item or a medication until you learn and understand how to use it, then that's the most important factor in theory about CO2. So if you don't have an automated injector, I don't think it makes a huge difference. In terms of connections, I'm going to show you that the connections should not make any difference, should be zero difference, because connections are very basic. All you need is long connection tubings and basically three-way valves and a CO2 cylinder that you can get from the OR. Okay, so this is basically the connections that all you need. On the right of the screen here is the connections that come with the AngioDroid or the automated machine. So it comes with one long connection tube, and it comes with that has a filter here, and it comes with this manifold that you can use if you want to alternate between saline, contrast, and CO2. You do not have to use this, but it makes your life much easier. So this is basic, simple connection. That's all you need to use. And you probably have a 3-way just to flush if you need to flush in between. If you don't have this device or these techniques, it's something basic. All you need is 3 items. You need a large syringe, so a 60 cc to 50 cc syringe. You need to have 2 3-way stopcocks, so one in this area and another area here. One is connected to the CO2 reservoir that you have. CO2 is available in all hospitals in the OR. All you need to go is to get to the OR and get a CO2 cylinder, and you can connect it. You aspirate the CO2 into here. You prime your system here 3 times. And basically, you make sure there's no air contamination, and then you're good to go. The difference between doing it by hand, there are other companies that have separate kits they sell for you for connections, but we're not going to go through it today. But the main difference by injecting by hand versus using the machine is by hand, the pressure is not very equalized. So you inject very hard at one point, very slow at one point. So it is more common for the patients to have pain, and more common for the images to be inconsistent. So that is the main advantage of using automated machine, that you have more consistency, more repeatability, and at the same time you have less pain because of the pressure that's equalized during the whole injection. So that's the setup thing. So we talked about this point before. This is the AngioDroid. If you haven't seen it before, it's very simple. It's a touch screen machine. You just turn it on, you choose the volume, you choose the pressure you want based on your experience, or that it comes with a booklet that tells you exactly what to do when, and that you will have to adjust with time, and I'll explain why. The main issue with CO2 in CLI patients is the pain. So the main goal is to decrease the amount of CO2 use as much as you can, mainly because of the pain. This comes with a compromise of sometimes having less quality images, but you can work around that, and I'll show you how we can do that. So example of a bad injection here, there's a contamination probably from the beginning, either with contrast, the patient moved, the post-processing is not adequate, versus a very nice, beautiful image here, almost as, or probably as good as a regular contrast agent injection. And actually, sometimes it actually gives you nicer, small microvascular branches because of its very solubility that it goes into very tiny spaces. So there are 10 golden rules that I think are the most important for doing CO2 in general. Then I'll talk about a couple of tips and tricks of CO2 related to peripheral vascular disease. So number one, you have to have a very high frame rate. Most companies have, or the machines have, CO2 software, so it will change the image. The more frame rate, the more sensitivity to movement, so the patient has to be very comfortable. So number one, you have to have a high frame rate. It's better to use an end-hole catheter so that CO2 is injected in one direction rather than a multi-hole catheter, because you'll be displacing blood in different directions. So sometimes it becomes a difficulty. The CO2 is pushing blood in one direction, then another direction. So end-hole catheter, or even injecting from the sheath, if you're doing an aortogram, is very, very beautiful. And I think it looks better than doing a CO2 angiogram of the aorta. A sheath is better than pigtail catheter. Reflux angiography is what I just talked about before. So you inject the contrast in a retrograde fashion via reflux, or you inject it antegrade, then you have a lot of reflex as you go backwards, so you can see both the top and the bottom of your access site without having to do another access site at the top or the bottom. Try to be as selective as you can. The further you are from where you're imaging, you're going to have to increase the volume. That's number one. And you're going to increase the pressure. So it makes the procedure a little bit more uncomfortable. So the closer you are, the better. Automated injectors is a benefit. If you have the luxury of using it, that's something excellent, and it makes your life much easier. And we pretty much now exclusively use it, except if for other issues out of our control. You need to wait 1 to 2 minutes between injection to get the CO2 dissolved by the body. The patient, whatever transient ischemia goes away. And if you're dealing with patients that have pulmonary hypertension, you need to make sure you actually increase the time, maybe 3 to 4 minutes, because you need the blood, the CO2 to wash out a little bit more. Rule number 7, if you're doing contrast in between your CO2 injections, please make sure you flush your CO2 out, or your contrast out, before your CO2. You have to have saline in front of your CO2 and not contrast, otherwise the image will become very ugly and you won't see very nice pictures. You need to understand the timing. Why is this important? If you're using automated machine, for example, when you press the button, it takes approximately 2 seconds for the CO2 or 3 seconds for the CO2 to be injected. So if you press the pedal too early, you'll have probably like 2 to 3 seconds of an empty image by the time the CO2 arrives. So you have more chance of movement, more chance of delay, more chance of worse images, as we know, and even for contrast. So you need to understand the timing when the CO2 is going to arrive and when to start your angiography. Elevating the area of interest, we talked about that before for example, for the aorta, but be very careful in patients that have CLI, because that might increase the ischemia a little bit and to make things a little bit worse. Post-processing, I can't stress this enough. You or your technologists that work with you need to understand this. Probably this is most important part of everything. They know how to do all the 4 factors. I'm not going to go through them now. I'm sure your technologists know it. AngioDroid have very good training in this, and they can teach most of your staff how to do this. It makes a big, big, big difference in having a nice picture in the end. Okay, so now I'll go through the rest a little bit faster. So here's an example of the aorta. On the left, a bad preparation and a bad image, and on the right, a very nice aortoiliac CO2 angiogram. So what are the main factors to improve your CO2 for the aorta? Number 1 is diet. People don't think about this a lot. So there's something called the low residual diet. It's hard to explain everything now. If you just go online and you search low residual diet, it just basically means patient has to eat healthy. So boiled food, grilled food, meats, coffee, tea is all fine, but they have to avoid anything that causes gas. So vegetables, fruits, gaseous drinks, fried food. They need to avoid this for the couple of days before the procedure. This will help a lot. We sometimes give activated charcoal the day before the procedure 3 times a day, again, to clear out the abdomen. So you're just basically trying to cleanse the abdomen. If the patient has a lot of bowel movement, you can give them antispasmodics. And of course, the patient has to hold breathing, which is a given thing we always do. The other factor that people sometimes don't think about is you can have very nice images by injecting retrogradely from the sheath, because the CO2 is so diverse and moves so far away. And if you inject enough volume, you'll see everything even better than an injection from the aorta. I'm not going to go through the numbers, but these are the standard numbers that come with the company and tell you if you're doing aorta, what's the pressure that you need to inject. So aorta and iliac needs relatively higher pressure. With time, you'll realize that you don't usually need this high pressure and needs a little bit more volume. So I'm going to jump this a little bit faster. Here's an example of what I talked about the aortogram. If you have a celiac artery, for example, if you have iliac artery stenosis. So on the left here, the red represents the gas. On the left side, you have a iliac artery stenosis. So if you inject from the top, the CO2 will find the area of least resistance. So it probably jump this area to a certain extent and go through collaterals and fill more distally. And you might miss very nice images of that side. If you inject retrogradely from the bottom, what you'll see is you'll see it going through that stenosis, going upwards and actually having a nicer picture. So this is a nice example of the advantage of doing through the sheath versus through the aorta. Both, again, are complementary. I already talked about this, so I'm going to jump it about the renal artery and tilting the patient. If you talk about the lower extremity, which is probably our main focus here, number 1 is make sure your patient is comfortable. Make sure you have the legs strapped if you can. I know Dr. Manzi has his specific techniques. I'm sure he's going to enrich us with it in a little while. There's also something called a double technique. So you don't always have to do a full injection with the machine. The machine has a flush function. So if you have a common femoral artery sheath here, and its tip is in the SFA, if you only do a flush, which 10 to 20 ml, which is minimal pressure, you'll probably see very nice pictures of here. Okay, and follow it immediately with that with a pressure injection. So if you press flush, then press the button, you have a flush, then immediately the injection, so you can see everything together with minimal amount of contrast. If you're already down at the popliteal area, again, a lot of people only use a flush rather than doing a full injection, so that they don't have a lot of ischemia. Fragmentation of the flow here is important, and I'll show it in a second. Selective injections, again, because you lose less contrast and less pressure or less CO2. Vasodilators are useful. I think something I find useful, I have never done it before, but I've seen people do it, is if a patient has very bad pain, they do popliteal, sciatic nerve blocks. So if you're familiar with doing nerve blocks under ultrasound guidance, or you can ask your anesthesiologist to help you doing the nerve blocks, that also helps a lot in very uncooperative patients. So again, showing you here, the pressures are very different from place to place as you go down further down. This is probably the more important slide, and then probably we're almost done here in our talk. So with the balance between pressure and volume, that's the main thing you play with. So the pressure, you usually need the pressure to be a little bit higher than the systolic pressure. So 30 to 50 millimeters of mercury higher than the systolic pressure. The higher the pressure is, the larger the column you have, the more blood displacement, the more ischemia. So for CLI patients, usually we aim for a bit of fragmented CO2, then we stack it together, have a nice picture. If it's too fragmented, you don't see a very nice picture. So you need to understand this, and with time, with experience, it will go. The other thing is the volume. If you have too little volume, you will have minimal displacement or partial displacement of the blood in one side, so you don't see the whole artery, then you need to increase the volume. So again, I can't give you magic numbers. We do a specific volume protocol for all our patients, trying to make things consistent, but it's a balance between basically pressure and volume, and with time, everything will be very clear. This is from the company. I'm not going to go through the numbers, just to show you. It depends on where you inject, the volume becomes different, the pressure becomes different for a short sheath versus long sheath versus long catheter. The most important part is the longer the if you're using a catheter, or the smaller the catheter, you will always have to increase the pressure because the catheter lumen is smaller. So you have a long catheter. If you're using a micro catheter, if you're using a 4 French versus 5 French, you need higher pressures. Otherwise, the machine will not inject. So disadvantages, I think we'll jump this because we talked about this in terms of pain. The most important part is, remember, you do not use it above the diaphragm. Be very careful when patients have pulmonary hypertension, and avoid it in right to left shunts because you have a lot of problems. I'm going to jump this to be as fast as possible. This is two important parts of this slide. Is be careful again in respiratory failure, and also be careful in patients that are taking nitrous oxide anesthesia during the procedure, because it accentuates the effect and you have to wait more time or give less CO2. So these are the two important points of the CO2 hazards. So remember, the respiratory failure and the nitrous oxide anesthesia. Examples, maybe just one, just showing a CO2 versus contrast. Looks pretty much exactly the same. Very nice images with post-processing. Here is how the CO2 versus contrast looks like in an image. You see the CO2 was faster to show the distal zone compared to contrast because it follows through the collaterals faster. And then this is just another example of below the knee vessels, showing how the image was nice, and actually sometimes looks a little bit better sometimes, but again, it could be the opposite. Pre and post intervention of dorsalis pedis and anterior tibial artery with CO2. So in conclusion, just to finish, I'm sorry I took maybe a couple of minutes extra from your time. Remember, CO2 is a complementary agent nowadays, I think, and it's not something of CO2 versus contrast. It has its advantages, its limitations. It is a technique you need to learn. You need to understand how to use it before you use it. Has nothing to do pretty much with having a machine or not. If you know how to use it, you know how to connect it, you know how to prevent an air contamination, then you're good to go. The machine will make your life easier, make your images better, make your patients probably more comfortable, but it's not an essential. It is important, and we use it essentially, but you can still use it without it. CO2 is the only safe contrast agent. My 2 cents about CO2. A lot of people ask us, how can we adopt CO2? I have 2 things to say about this. Number 1 is understand it very, very well, just like you're understanding any disease that you're going to treat before you treat the patient. Number 2 is use it even when you don't need to use it. That's when you're going to start learning and understanding how to do it. These are the easier patients. They're not going to have that much pain. It's easier to understand it. Use it for IVC filters, for example. It's so easy. It's so fast. And it actually shows you the renal veins very easily. Use it in angiograms, diagnostic, whatever you're doing. Use it as much as you can, and until you know exactly what you're doing. But again, make sure you understand it very, very, very well, because it does have its own complications. It does have its own issues, and you don't want to start off with difficult patients, such as patients with pulmonary hypertension. And thank you very much.
Thank you, Dr. Shagran, for this very informative talk. And I really like your last conclusion, because it's extremely important for the people to have the trust a little bit to use, but also to be cautious. And I really like the ideas to encourage them to use it when it's not really necessary. For example, we started using it some time ago to train the technologists in doing venography in patients who are going to go for AV fistula. So before they go for their fistula, we do the central peripheral venography actually using CO2. It's a very good tool. You see all of this is beautiful. Thank you, Dr. Shagran. Now, our next talk, I presented Dr. Manzi before, but Dr. Manzi, as everybody knows, is going to talk about the use of CO2 in CLI. Is it a fantasy or it's a real option? Dr. Manzi, please.
Thank you, Mahed, for the nice introduction, and thank you to Shagran for the very beautiful presentation, very didactical, very complete. And thank you for the poll question, because the common answer, the most common answer about I'm not using CO2 because I'm not comfortable in using it. It's really it's the main reason of the in every place to not use the CO2, because CO2, especially the Android machine, is very easy. But as Shagran underlined, you have to use in every single patient to be comfortable with the technique, to understand the effect, and to optimize and standardize the technique. So thank you for this extra minutes. I'm going with my presentation. Okay, this is my disclosure. Okay, this is the way we every day prepare the patient to try to let the patient much more comfortable during the procedure, helping the patient to stand with the foot. There is a plexiglass support, and we bend the foot with some adhesive bandage. And you can see this is the standardization of the procedure we use in the most of patients. These parameters, 120 millimeters Ag in pressure with just 20 ml of volume directly from the sheet. We use, as you probably know, a 6 French Terumo short sheet, 11 centimeters. Of course, the procedure begins with a puncture of common femoral artery under ultrasound guidance. So you can see here the injection directly from the sheet with a bolus of 20 ml, I repeat, with 120 millimeters Ag in pressure. You can see the standardization of the procedure just to train our brain and our eyes to interpret the imaging. This is the SFA with the same parameters and the same radiological projection, 30 degrees external oblique. You can see here the occlusion of popliteal artery P1, P2 extended to P3 and below the knee bifurcation. Again, always from the groin, the below the knee vessel in the lateral projection. This is a 30 degrees internal oblique. You can see here the imaging is acceptable. I think it's not so different from a contrast medium injection of iodine contrast medium. Of course, this is the only peroneal is patent. And to finishing, we perform a lateral view of the foot, and I remember the injection is always from the groin. You can see we try to optimize the magnification, and I remember the correct criteria for this projection is to see, we have to see the base of the fifth metatarsal bone, and we try to calculate the late arrival of contrast medium, and you can see the acceptable imaging in lateral plantar and posterior tibial artery. Then we perform an anteroposterior view of the foot, and we perform a 2D perfusion angio just to evaluate the efficacy of our procedure. Of course, with this kind of projection, the main enemy is the little movement of the foot in this direction, so sometimes could be difficult to evaluate with CO2. The comparison before the procedure and after the procedure, and that's all. So that's why if you see here, in the last 5 years, we improved the use of the CO2, and today, probably the entire amount of patient we study with CO2. You can see here, 98% of patients are studied and treated with the CO2. And if you see to this slide, there was an improvement in the zero contrast procedure. So in the beginning, we tried to, and we still do it, but to integrate the united contrast medium together with CO2, especially with super selective injection in a very small amount and of contrast medium and diluted contrast medium. But the tendency is to arrive to a zero contrast procedures. Here, the standardization of the injection, and that's why now we use the parameters I showed you in the slide before during the movie, and so we use the 120 millimeters AEG pressure with a bolus of 20 ml. That's exactly the picture I showed you before. The conclusion of this attempt to standardize the procedure was, of course, a huge save in the use of contrast medium. You can see we saved more than 10 liters in 1 year, and so we reduced not only the cost, the money cost for contrast medium, which is very cheap actually, but the biological cost in reduction of the acute kidney injuries, and above all the chronic kidney injuries that are leading to dialysis. You can see here an analysis benefit cost. It was possible to save in 1 year almost 26,000 euro in 2017 just using the CO2. And so the percentage of cost reduction is really huge and really useful for the patient. So my poll questions are very, very simple. How many patients could you treat with complementary approach? I mean, CO2 and contrast medium, up to 25%, from 25 to 50%, or more than 50%. Should be the goal in our real practice. But the picture of the reality, I don't know, because it's very important to realize that the integration of contrast medium with CO2 is really useful and could be probably in some situation could be not avoided, but could be reduced very, very, very well in with the experience and with the training we have when we use in every day this technique. Of course, when we arrive to use CO2 and contrast medium in more than 50% of patients, could be a first step to arrive to a contrast zero procedure, which could be the ideal target in our everyday practice. So now maybe we are ready to see the answer.
Up to 25% and 31% of the people, they voted. And from 25 to 50, 25% of the people. And more than 50%, 43. So majority of people, or at least just less than half, are voted for more than 50%.
Fantastic. The second poll question, which is your main purpose in choosing CO2 rather than contrast medium for a patient with no specific clinical indication? Protection for renal function, technical advantages of cost savings. Again, the cost for a patient obliged to perform a dialysis is really, really huge. And the total amount of money for a health system is really impressive. So that's why if we can protect kidneys, and if we could arrive to zero contrast procedure for the patient, would be a very, very nice options. Now maybe we are ready to see the answer.
Yeah, okay. So, okay, wow, this is interesting. So 80%, they said they're going to use it to protect the renal function.
So this is a very, very good message because everybody is realizing the importance of using CO2 to protect kidney function. Especially when you treat in CLI, you can see here the food before and after procedure, and you can see here the quality of the imaging with an injection directly from the groin with the parameters I showed you. Again, before the procedure, after the procedure, anterior-posterior view, always with CO2, and I can show you the final run after the procedure with the CO2. Again, before the procedure and after the procedure, this is the anteroposterior view. There is a little bit of movement, but in the lateral view, you can see how acceptable and nice is the imaging. Just to show you, in the complex CLI patient, is it possible to use the integration of contrast medium and the CO2? You can see the study always from the groin. This is a 6 French 11 centimeter Terumo sheet, antegradally approached. This is the SFA. In the next, you will see the below the knee vessel, and you can see how slow is the flow in the below the knee. There is a long occlusion of anterior tibial artery and the distal occlusion of posterior tibial, and this is the aspect of the foot with the occlusion of common plantar and dorsalis pedis. And you can see here, we can use during the procedure, this is a short movie showing the use of a collateral technique, transcollateral technique, because we achieved the perforation in the distal posterior tibial artery attempt of recanalization, and we are using a microcutter from Tokai. Is a 1/4 microcutter together 1/4 Asahi Fielder XT wire to navigate through the collateral, and it was possible, you can see here, to cross the tight stenosis in that area, and through the collateral was possible to arrive in the lateral plantar artery and back to the posterior tibial. And again, you can inject through the microcatheter or to the balloon just 1 ml or half ml of diluted contrast medium, just to integrate the imaging as you know, to fill a very long and very small catheter, you have to increase the pressure of CO2. But here, with the half ml of contrast medium, you realize you are in the true lumen, So it was possible to create a retrograde dissection of the common plantar artery, and we could meet the wire in the distal posterior tibial and having a nice posterior tibial recanalization and anterior tibial recanalization. I can show you here the CO2 angio to evaluate the result with an anterior tibial patent with a small fistula. I remember you that the low viscosity of CO2 very often shows some communication with the veins, and if you repeat the acquisition with contrast medium, you can never see this fistula, and this is the final foot after the recanalization. Again, in CLI, you can use the same parameters just to study the foot and trying to improve the foot distribution with the navigation, just with support of a smart mask with CO2. So even a smart mask is possible with CO2, and you can have the road mapping for your procedure with CO2 as well. And you can see here the ballooning and the final evaluation in the anteroposterior view with the very nice distribution of CO2 in the forefoot. I don't know if we have time. This is another case quite old, but you can see here the study of SFA and popliteal tract. We have an occlusion, a complete occlusion of popliteal artery and below the knee vessel. This is a lady, so that's why we were obliged to integrate the imaging with a very small amount of contrast medium. This is a VisiPac 270, 50% diluted, just 9 ml from the groin, and you can see the imaging. And after the supera stent implantation, you can see the evaluation with another bolus of contrast medium, but you can see the flexion angiography with CO2 as well, with a direct injection and a very nice flow. Now we can show you a comparison below the knee vessel, again with CO2 and the final foot in anteroposterior view. Here we have again a small fistula with no clinical significance, and this is the final imaging into the foot. Sorry, okay, it's working, and this is the final aspect in lateral view of the foot with a very nice direct flow in anterior and posterior tibial artery. Perfusion angio shows a very impressive increase in the flow. So limitation in our everyday routine job is the movement. If the patient stands, you can see here how good is the imaging with no problem. It's very easy to have movement in the anteroposterior view. You can see here the final acquisition. There is a movement of the foot. That's why we try to help the patient with a bandage. And in some cases, I personally perform the sciatic nerve block under ultrasound guidance, which is a very good help for the patient because we have the no pain effect and no movement effect. And the only not mandatory, but you have to pay attention Contraindication is the respiratory insufficiency with the PO2 less than 50 millimeters AG. And you can see here again the difference between a good stand imaging with the movement. So in conclusion, CO2 angiography is actually our first choice for all our critical limb threatening ischemia patients. And of course, we are trying to evaluate definitively the real amount of renal insufficiency reduction in our population in the last 5 years since we started the extensive use. And the impression from preliminary data is that we succeeded in reduce more than 60% of our chronic renal failure. Thank you very much for your attention.
Thank you very much, Dr. Manzi, for this very informative talk. And it carries a lot of experience, of course. You have a lot of interesting cases. Maybe next webinar will show us how do you do this block also, so we can learn next time.
Yeah,
because
sure,
we do a lot.
sure.
Yeah.
Sure.
Now, I have a question now. How good CO2 in quantifying a complication, especially like dissection? How good CO2 in quantifying it, and how do you feel comfortable just doing CO2 to leave the dissection back there, Dr. Manzi?
Okay. You know, the low viscosity of the gas sometimes underestimate the lesion. So we have to train our brain and in our view to recognize the dissection flaps, and sometimes we have to interpret the amount of dissection, because if you inject contrast medium, very often you can cancel dissection. With CO2, especially changing the projection, you can see the flap, but it's difficult to evaluate the hemodynamic significance because of the low viscosity of the gas. Can pass everywhere with a good speed. So that's why in the last year we trying to integrate with another imaging, which is the intravascular ultrasound. So if we have the suspect of a flow limiting dissection with CO2, we try to evaluate with the IVUS in order to understand if we need to treat the dissection, or if could be acceptable to wait and watch if that dissection can reduce the probabilities to have a wound healing in that patient.
Okay, thank you. Maybe a question for Dr. Chagran is, you talked about it's a little bit painful to inject it for particular CLI patients, especially if they have a single run of vessels. Now, if they are not under sedation or anesthesia, for example, and we're not able to do the block, is any tricks you can do to help reduce the pain, or a technique that help to get an optimal image? Because if you're going to keep injecting contrast, a small amount of iodinated contrast because of the pain of CO2, we will not be achieving what we want it to be, just using CO2 predominantly. So any tricks and techniques that can help the people?
I guess the main thing is basically trying to make the patient as comfortable as possible. If you can give sedation, or if you can give nerve block, that's beautiful. If you can't, I think probably the best way is to not use an actual pressure injection, is just use the flush technique, where you get a catheter close, for example, to the popliteal artery, and you do a flush technique. So it's basically just flushing CO2 in the artery. So it's much less pressure. It's more fragmented. So basically you're displacing the blood less. So they'll have less pain. But at some point, sometimes actually it's not possible, unfortunately. You have to wrap the leg. Like again, Dr. Manzi showed the plexiglass they use. We just wrap it with the two, what's it called? These small wraps that we have with the angio table, but that's it. Yeah, I'm not sure of anything else. Maybe Marco has another opinion.
No, to be honest, the parameters we use, so 120 millimeters Ag with 20 ml, are in the most of patients permits a procedure pain-free. It's very unusual to have pain. The problem is if you have a complete occlusion of SFA and popliteal tract and below the knee. So when you have no possibility to expand the gas, you may have pain. So we inject some lidocaine in the artery, directly in the artery. It's possible to inject up to 200 milligrams of lidocaine intra-arterial with no systemic effects, and this helps a lot the patient. Another trick is if you inject through a Bernstein catheter at the popliteal level in pin 1 or P2, if you have a complete occlusion of 3 below the knee arteries, you may still have pain. So inject again lidocaine and use the flush because the volume is less, it's only 10 ml, and because sometimes the machine can stop because feels the resistance to the injection when you have a complete block and stops the injection. But if you use the flush, this cannot happen, and normally the imaging is possible with no pain. In the extreme cases, we use the sciatic block. But to perform the sciatic block, you have to know that patient needs that sciatic block, because you have to do at least 25 minutes, 30 minutes before the procedure. So it's a logistic problem to plan in the everyday activity. The sciatic block you need to perform 25, 30 minutes before the procedure. So you need time to perform the block, and then you have to wait for the effectiveness of the block before starting with your procedure. So that's why we have to know that patient needs the block to program and to plan the block. Otherwise, on all the other cases, normally it's possible to manage the procedure with the lidocaine intra-arterial, with the bandage of the foot, and with the use of 20 ml and 120 millimeters Ag in pressure.
Very good, thank you. There is a question from the audience saying, can it be used, the CO2, above the diaphragm, example, upper limb AVF?
I would be very, very prudent in using above diaphragm. The effect of gas into medullary artery could be very, very dangerous, so nobody knows. And if you have arterial venous fistula, the passage of gas could be faster than normal.
But if it goes to the lung from the fistula, it won't harm, right? If you are controlling it not to reflux back, and if you, let's say your catheter is in the brachial artery.
Yes, but if you have a communication, intra-arterial communication, or a communication with the carotid tract, I don't know if it's quite safe. Yes, absolutely. You have to be sure the patient has not PFO.
Number one is make sure if you're doing that there's no right to left shunt at all. And the second most important part, especially if you're brachiocephalic, not radiocephalic, that you don't inject too hard, because you will easily reflux back into the subclavian if you do a too hard injection if you're in the brachiocephalic.
Shagran told us that it's possible to study the contralateral limb using an injection with a high volume from the groin, the gas can show the contralateral limb. So the reflux of the gas is very easy.
Yeah, yes, yes. Now, because we are in COVID time, there's a question said to use automated CO2 angiography in COVID-19 patients. What's your viewpoint? Maybe Dr. Manzi, you're dealing a lot with COVID patients in Italy.
Fortunately, we did just one with the sure positivity. I don't know. In the most of case now we perform the screening for COVID-19 patient. So if you have a patient with a severe respiratory insufficiency, you have to wait a lot between an injection and another one. So you have to give time to the patient to expel the gas through the lung. But remember, if the respiratory insufficiency is severe, it's better to avoid.
Very good. Dr. Shagran, any experience with this?
No, we haven't got a specific patient that needed angiogram. We've done a few COVID patients for other procedures, but I think the same rule applies as patients that have pulmonary insufficiency, that the main rule is just to wait in between, just like Marco said. Nothing. I have nothing to add.
Very good. Still, we don't have more questions from the audiences, but I know we're discussing the use of CO2 in peripheral vascular disease particularly, but if we want to expand more use, what do you think about using it in venous intervention? Maybe Dr. Manzi and then Dr. Shagran can comment on this.
I repeat, if you are sure there are no problem with shunt, with patency of alforamen, probably you can do. The problem is that because of the low viscosity, you can see a lot of vessels. So, you know, when you inject contrast medium in venous system, it's difficult to understand the anatomy because you can see a lot of vessels. And with CO2 could be worse. So I don't know, probably we need experience. Another issue could be the valve. With contrast medium, if you have a valve, no contrast can pass the valve, so you cannot see beyond the valve. My impression is that because of the low viscosity, you may have good visibility of the distal vein, but this could be a problem because you have the diffusion of the gas in all the collateral. So I don't know. To be honest, the real answer is I don't know.
We tried a few times in patients with central venous occlusion in the chest, which was reasonable. But when they have very, very big collaterals, it's a nightmare. It actually makes you see even the smaller collaterals that you really don't know exactly where you're going to go. We haven't tried it in the pelvic venous obstruction, but I'm assuming that's even going to be more difficult.
Yeah. We've tried it actually in the past to do upper extremity venography for patients who are going to have AVF. It's actually beautiful. You see the vessels going, see the CO2 going and specifying the cephalic and basilic veins very well without using tourniquet or anything actually. Okay, so we have a question from the audience. Do you use intra-arterial lidocaine routinely? And if yes, what is the dose?
Yeah, the normal dose is no more than 200 milligram. 200 milligram means 20 ml. Sorry, with our products, 200 milligrams is 10 ml. of lidocaine 2%.
Okay. All right.
Personally, I injected in some patients more than 450 milligram with no systemic effects. I mean, arrhythmia, cardiac effect. But we published 200 milligrams.
Okay. Very good. I guess we are coming to at the end of this webinar. I would like, on behalf of Angiodroid and Saudi Interventional Society, to thank Dr. Manzi and Dr. Shagran for this wonderful presentation and for this very informative talks about CO2. And I hope people and audiences listened carefully to what you said regarding the advantages and precautions from the use of the CO2. Thank you very much. Dr. Manzi, you want to add something at the end?
Thank you. Thank you.
Thank you. Shagran, anything?
Thank you very much. It's always a pleasure.
All right.
And hopefully we'll see each other soon.
All right, very soon. Okay, see you guys.
It would be very, very nice to have the possibility to travel again, but
again we see you in our hospital again. All right.
I don't know.
Goodbye. Inshallah. Things will happen, inshallah. We will be in a good shape.
Inshallah. Thank you very much.
All right.
Thank you.
All right.
Have a good night.
Thank you very much.
You too. Bye.
Thank you, everybody. Thank you.